So what do we have to go through to get British Columbia fully networked with telestroke so that every citizen who has a stroke has the possibility of being assessed with a system like this? Well, it's a big job. In the initial, next slide. In the initial pilot, that the consulting sites were set up here in Victoria and in Vancouver, and in order to get the consulting site up and ready, we had to talk to the neurologists and see if they're prepared to take part in this. Not all were, and so we drew on the neurologists who were already specifically engaged in the Stroke Rapid Assessment Unit, which was a subset who had a particular interest in stroke. We had to choose a place to put it. We chose to put it right where the action was, where we were sitting anyway. So in essence, we can be seeing people face to face in that clinic, or we can be seeing people on the screen. And that particularly applies if we start to broaden our scope from thrombolysing the acute stroke in the 4.5-hour window to managing some of those patients whose stroke have got better but are still in a high-risk situation, the TIA patients, the mild stroke patients who are conceivably going to be getting worse. So we would see bringing those patients in under this system and with the neurologists sitting in this location. As I mentioned before, here on the island, we working along previous existing referral relationships. But when it comes to setting up a provincial referral system, then you've got a new situation where somebody in Terrace has to think about calling a provincial number and talking to a neurologist that maybe they've never met before or know at all. So there are going to be some new referral pathways to be going down. Diagnostic imaging is critical in this whole piece, and I think one of the big struggles for setting up the mainland's telestroke has been the various bridges that had to be crossed, the electronic bridges that would allow the CT scans from Peace Arch or Chilliwack to be visible back in Phil's shop. On the island, we didn't have that problem because we are already on one PAC system for the whole island. So we've been regularly looking at CT scans from the other sites up and down the island. So that wasn't essentially a big hurdle. It remains a big hurdle to get the rest of the province linked in this way. In our system, there's no pushing or pulling the images. As soon as the image goes on to the system in Campbell River, it's our system, so we can pull it up. So whenever we search for a patient, you're searching the whole of Vancouver Island. When it comes to getting the referring sites up and running, I think that's more of a struggle, and obviously we've got two main consulting sites ready now, but now the job is to enlist a number of further referring sites. And really it's not just the process of getting somebody set up technologically to get a bit of video conferencing going. It's really the process of getting a site happy with managing stroke and happy with having somebody else co-manage that with you. And that can be a hurdle in both instances. For the site that's naive, there's a whole process of becoming enabled to manage acute stroke from the laboratory services providing the requisite lab materials in suitable time. For medical imaging, to get that door to imaging time down to an appropriate number. Getting your CT scan in under 25 minutes is a target which we like to aim for. If you're taking an hour to get a CT scan of somebody, it's not fast enough. So there's various things that stroke centers have gone through to ensure that the CT scan is done rapidly, including leaving the patient on the gurney when they arrive by ambulance and taking them straight through to medical imaging, things like this. So imaging is a big issue. The access to TPA, having it there in a clot box or whatever, with ready access for the emergency room. It's got a pretty good shelf life, so you can have it sitting around. The access after the thrombolytic to some kind of intensive care environment, that's a variable one. And although initially in Victoria our patients all went to the ICU, we've subsequently working more with a system where by the time everything's done, they've spent 6 hours in the emergency room, and we send them on up to the neuro floor where they're comfortable with picking up the patient at the 6-hour mark. But in a smaller center, the ICU would be the appropriate place. You therefore need buy-in by your intensivists to be wanting to take these cases on. And that's not always a given. We thrombolized a patient with telestroke recently, and were somewhat disturbed to find that that patient was stuck in an ambulance and sent to Victoria post-TPA for their post-thrombolytic care. So there can be local disturbances at various sites which might preclude a ready taking on of this new clinical load, although it's not a large clinical load numerically. And not only the intensive care, but the ability to kind of spring a one-to-one nurse at short order for these patients, because you're not sitting around booking them. They come in and they require this nursing right off the bat.